So I had quite the experience today at the ALS clinic, and even though I've been a doctor for the past 5 years, ALS is still a little bit of an enigma to me in terms of the comprehensive treatment that they get. But today was quite the eye-opening experience, and I wanted to share with you guys today. So let's get ahead and get into it. What's going on, you guys? My name is Dr. Tochi, and today I was in ALS clinic. And for those of you guys that don't know what ALS is, ALS stands for amyotrophic lateral sclerosis, which is a progressive neurodegenerative disease that affects your upper motor neurons and your lower motor neurons. And that leads to a lot of symptoms such as weakness, fasciculation, so spasms. You can also have issues swallowing, issues breathing, and it's quite the progressive disease. So you start losing a lot of these functions throughout your life. I think the prognosis of people that usually get ALS is that they usually die from diagnosis, I think like 5 to 7 years after diagnosis. And not only is it quite the physical limitation that it imposes on your life, but today I've learned that it can have a lot of spiritual and even emotional aspects as well. So let's go ahead and get into it. The setup of the clinic was actually quite interesting. The patient is sitting in one room with their family member, whoever it is, and instead of having multiple different appointments with multiple different specialties spread between days to weeks, all of those subspecialties that are related to ALS are swinging through that same room, each spending about 30 minutes to an hour and addressing whatever concerns that they have for ALS. A couple of the people that we see, I took a bunch of notes today because I felt like I just really needed to keep all this down so I could share it for you guys. But the subspecialties that you actually deal with ALS is neurology. You also have pulmonology, so the lung doctors. You also have palliative care. You have physical therapy. You have the swallow specialist, and then you have the nutritionist. So 6 different subspecialties. And I can talk to you guys why all of this is really important. So let's go ahead and first jump into the first subspecialty, neurology. Now, neurology is responsible for not only diagnosing ALS, but also the treatment strategies. There's a couple of FDA-approved medications that you can use to treat ALS, such as riluzole. I think there's another one called edaverone or something like that. And then the third one I'm not too familiar with. But these 3 special medications, although they've been FDA approved for ALS, they help a little bit in terms of slowing the progression of the disease. But there's not too many other medications to actually either reverse or even just halt the medication or the disease outright. So these are 3 medications that they use. They can be in pill format. I believe some of them are in liquid format as well, which I thought was pretty interesting, which is pretty interesting as well in terms of how you get the medication in later, but we'll talk about that later on. But the neurologists, I learned so many nice little tidbits from them in terms of subtle signs of how the actual presentation of ALS comes as. And some of the things that we are doing were not only a complete full neuro exam, but I was also getting to hear some of the things that they were looking out for. Like I mentioned before, it affects your lower motor neurons. So one of the main symptoms that you can have is weakness. And one of the main things that they can have is weakness, not only in their ability to eat, their neck muscles, their jaw muscles, their hands, their legs, but one of the things that she actually mentioned that's really important is because whatever dominance of your hand is, because our patient came in primarily presenting with right upper extremity weakness, the dominant hand or whatever is being affected, your dominant hand should also always be stronger than your non-dominant hand. So she was doing a strength test today, a motor exam, and they actually saw that the strength in both of the hands were about equivocal and about the same, but that's actually a negative finding because your right hand or your dominant hand should also always be stronger than your non-dominant hand. So that's something that I thought was pretty interesting that she pointed out to me. And then some other things that you can hear as well is that you start having some voice changes. So you start having bulbar changes. So that's the issue swallowing, the speaking. And ALS, one of the things that you can progressively lose is your ability to talk because the weakness starts affecting you so globally that your ability to talk just goes away completely. One of the things that you can actually hear is that the sound and the pitch in your voice actually gets a little bit more like screechy. So one of the things that we did was like la 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 e. And if you have alterations in that actual sound, that's a sign that the ALS is starting to affect your voice. And that's a little bit of a warning sign because that means that it's going to start progressing to the point where you actually stop talking entirely. So I thought that was pretty interesting. Some other neurology things that we mentioned as well was also the subtle sign of coughing is, are you starting to cough a lot more after eating food? Are you coughing a lot more because you're having acid reflux? If you're having acid reflux, how do we treat those triggers, or what triggers do we need to be looking out for? It was pretty comprehensive, but the main thing that they were asking as well is how long is it taking for you to finish foods? Are you having to go from like, oh, I finished my food in like 10 minutes and now I'm eating and chewing and all these different things for like 30 to 40 minutes? Those are all really subtle signs that you can ask your patients with ALS to kind of see how the progression is in the weakness in their neck muscles and their ability to actually eat. The other things that you can kind of check to see how the weakness is progressing is checking your more so core muscles. So your proximal muscles, your arms that are closer to the shoulders, one of the things that they pointed out is that your ability to push someone's shoulders down and once they're shrugging up, you shouldn't ever be able to push that against their will. They should be able to be strong enough to hold that up. And then another thing too is that a person's ability to hold their jaw open, if you go like this, a person should not be able to push your jaw up if you're forcibly keeping it open, which I thought was pretty interesting. I've never really actually thought to do that on a physical exam maneuver for an ALS patient, but then again, I haven't had too many ALS patients. So those are some subtle signs that the neurologist was pointing out to me today when I was doing an exam with her. And the other thing as well is that if you're able to go like this, puff out your cheeks, you should not be able to push someone's cheeks in, like kind of tapping on it and air is coming out, because that's not only a sign of weakness in your face, but that's also going to make your ability to do pulmonary function tests, so like breathing exercises, to be even harder. So we call those PFTs. So these are all kind of like subtle signs that the neurologist is pointing out to me today. The other people that we actually saw today were the swallow specialist and the nutritionist as well. One of the things that you really want to make sure your ALS patients don't lose is not only weight, but their ability to eat. And two of the most prognostic signs that we use to prognosticate patients and how much time that they have is their ability to swallow and their ability to breathe. Those two things, if they start going away, that's actually a bad sign that the ALS is actually starting to progress to a point where we're gonna have to start talking about advanced care planning and what we want for the future. So the nutritionist was asking a lot of things like, how many times a day are you eating? How many meals are you actually skipping? How much intake are you getting in terms of fluids? And some of the other things as well is having to talk about different maneuvers that you can do, because usually your weakness in your arms goes away. So sometimes being able to feed yourself, that starts becoming difficult. You start dropping things unintentionally, such as like utensils to eat, like forks or knives or spoons. Those are all things that you can lose. And then they also do something called a modified barium swallow, which is the ability to actually see how you're actually swallowing. So that swallowing reflex starts to get weaker and weaker and weaker. So they do that every 3 to 6 months to see, are you having any issues in actually completing your swallow reflex? Because at some point in time, if you're actually wanting it as a part of your goals of care, you're gonna need to get some sort of feeding tube, mostly like a G tube, placed there so you can actually get that nutrition in. The next people that we saw in the clinic were the physical therapists. And like I said, you're gonna have a lot of weakness. You're gonna start losing your ability to walk. So one of the things that we actually did was a prolonged get up and go test, which is to kind of assess an ability and your likelihood to actually start having falls. So what we actually do is that we left the actual clinic room. We had the patient sit there, get up without using their hands to push off their knees to get up, because that's one of the signs that you can tell that someone's getting weaker, is if they're having to use their hands to push up against their knees to actually get up. And then we have them walk back and forth to a chair and then run back and forth to a chair a little bit more briskly. And this is all to kind of see, like, is this person starting to become a little bit more of a fall risk? Usually about 10 to 12 to 14 seconds. Shouldn't take you that long to get across I think about 10 feet. And if it starts becoming longer and longer and longer, we worry about this patient starting to become a fall risk and losing their ability to walk. One of the other things that we did is that we actually set up an actual brace for a patient. So we actually had a foot brace that we had, and we actually took the patient's shoe, we took the actual sole out, and then we actually Jerry figured the sole and cut it to be actually fit the actual brace. And then we put the whole brace into the shoe and had the patient put it on, and we had them walk around to see how it fit for them. So that was actually quite interesting, because not only have I not really worked with a lot of physical therapists and seen what they do in like the clinic setting, I've been able to kind of see how they actually choose different actual braces and castings that they'll need for getting around and maneuvering around. We should be able to have them see occupational therapists if they become a little bit more progressive in their ALS disease. And I think of physical therapy as like large body movements, but occupational therapy for like more fine motor movements. And that's like, you know, writing with a pencil, using utensils. And those are people that you can actually see as well to kind of strengthen those muscles to actually can maintain that ability to do that, because once you start losing that ability, we start to relying on other people and having caregivers and using family to try to get nutrition into a person. And then the final people that you actually talk to in ALS clinic is actually the palliative care specialist. And the reason why we have palliative care in the actual care of ALS patients is because not only does this disease affect you physically, but also affects you really into the future for what type of medical decisions that you have to opt in and out for, but also ALS is something that affects multiple different systems and causes a lot of different symptoms. Some of the things that you can actually start having is one, pseudobulbar affect, which is where you actually have inappropriate laughing or crying in social situations, which can be quite debilitating and embarrassing for patients, because imagine having a normal conversation out in public and you just start hysterically laughing or hysterically crying. It's quite disruptive to actually be having that, especially if you can't control it. And so that's one of the symptoms that we actually look out for, as well as the neurologist is looking out for. Some of the other symptoms that you can have are cramps, spasms, pain from joint stiffness and from the spasms. You can actually have a lot of mood changes, and that's something that our patient dealt with today, which was anxiety. So some of the other mood changes that you can have is depression, anxiety, irritability. So that's some of the things that can happen as well that you can help manage. Some of the other symptoms that you can actually have as well is shortness of breath. So we actually look out for that as well and seeing, are they having shortness of breath that is quite debilitating for them, that they're gonna need to start some sort of opioid for, such as morphine or oxycodone, to kind of help with that sensation of shortness of breath. So that's another symptom that you can have as well. And then some other symptoms that you can have are head drop. So as I mentioned before, one of the symptoms that you can have is weakening in not only in your peripheral arms, but also in your central area. So your shoulders and your neck muscles start getting weak. So eventually, when it gets progressed enough, you'll start having head drops. So they won't be able to hold their whole neck up. So one of the things that we have to do as well is seeing if we need to talk to physical therapy or some of the other subspecialty to see if we need to get a neck brace, either rigid or soft or semi-rigid, to help keep their head up so they're not just laying like that the whole time, which can induce some spasms in the neck. So that's some of the things that we also ask for as well. But some of the other things that we talk about as well in palliative care clinic are talking about some of those end of life situations. The patient I had today was still pretty independent, still able to walk around, feed himself, having a little bit of weakness. He's not at that point where he's just bedbound, not able to talk, not able to walk, not able to eat on his own, but that can be a reality for him in the future. In fact, it will be a reality for him in the future that at some point he's gonna lose all those functions. So we have to really be forefront in thinking in terms of what we actually need to do for this patient at the end of life. So some of the things that we talk about is, would you want to be on a ventilator or end up with a tracheostomy? Because eventually your ability to breathe on your own is going to become compromised. So you may need a tracheostomy and be connected to a ventilator. And some of the other things as well is, do you want a feeding tube if it gets to the point where you can't eat? Or do you want to just say, hey, if I'm not able to eat at a certain point, I don't want to be in a world or live like this, living without the ability to eat. So we talk about, do you want a G-tube or not need a G-tube? And some of the other things that we did today was also talk about their mood and do you need to start an antidepressant? Because one of the things about ALS is that not only is it physically affecting, but like I said, it affects your mood. And imagine you having a condition that is slowly chipping away at not only your physical capabilities, but also your mental capabilities. And the reason why that's so eye-opening and something that we don't really think about too much in medicine as doctors that don't really take care of ALS is, if you're slowly losing all the abilities to do the things that you can do, your independence and your dignity at a certain point, you're gonna start feeling very sad about that, and rightly so. So imagine you are someone that is very prideful on having your independence and being able to do that, especially if you're a very physical person, losing all those abilities. It's like almost losing a part of yourself. So these are very important questions to talk about with your patients, and also see if we need to do anything to kind of help in terms of their mood control. So those are all the things that we kind of consider, and also talking about DNRs and full codes and all those things of that nature, talking about end of life situations and when they would want to be in the hospice category, because you do have specific hospice criteria for ALS patients, but we'll talk about that for another day. The last person that we actually saw was our pulmonologist, so the lung doctors. And like I said, you lose your ability to breathe on your own, you start having a little bit more shortness of breath. So one of the things that we can do is PFTs, which is pulmonary function tests, which can give us an idea, when is it possible for us to put in a feeding tube, because you shouldn't have to wait until the end stages to put in a feeding tube. We usually start doing that when your vital capacity, I believe, is less than 30 to 50%, around that range. So we do that to kind of see, do this person need a feeding tube? And also, does this person need a non-invasive positive pressure machine, such as CPAP or BiPAP, to sleep overnight? Because if you're not able to breathe on your own very well overnight, we don't want you just like breathing very shallowly and having a lot of CO2 or carbon dioxide build in your system, and then you get knocked out. So a lot of patients that are having ALS will eventually need a BiPAP machine to help them sleep overnight. So overall, it was a pretty eye-opening experience. I learned a lot of different tidbits on managing ALS patients. Let me know what questions you guys have about ALS and how the care was. I thought this is honestly the best model for how ALS patients should be cared for in the outpatient setting, because not only is it very patient-centered, like, hey, let's not just spread all these appointments out, let's make it our patient sits here and everybody just needs to come in and talk about it. And it also makes it easier for the providers because they can just talk to each other in the moment, like, hey, you saw X, Y, and Z, or you saw so-and-so in there. What did you think from your specialty standpoint? And is there anything that I should be considering moving forward? Overall, I thought that was a great experience. I really want to share more experiences with you guys in terms of things that I am seeing, even though I've been in this career for quite some time now. But let me know what you guys think. I'll see you guys later. Peace. Have a nice day.